Yeah, thank you for the kind introduction, Joe. And today I've been tasked with talking about transitioning from DMAB because in Australia we have a unique problem where we have 85% of our patients on DMAB. So with that, these are my disclaimers. An overview of my talk. I just thought I would talk briefly about the history of denosumab in Australia and just run through, and I think you might have mentioned some of the transition studies that were in the ASBMR task force, and maybe bring you to bench to bedside and get you to give you a journey about how we got to what we're doing clinically at home. And I thought I'll finish off with the transitioning of DMAB to romosozumab. So DMAP in Australia, and I think with that, I'd just like to give you a brief background of PBS, the Pharmaceutical Benefit Scheme. It's part of the Australian National Medicines Policy. It subsidizes costs of prescription medicines. Why is this important? Because you'll quickly realize why DMAP is so commonly used. So it's $31.60, and then for pensioners or people on healthcare card concession holders, it's $7.70. And if you reach safety net threshold, the general public pay what pensioners pay, and pensioners then get it free. So DMAP in Australia was first PBS listed in 2010 for women aged greater than 70 or T-score less than or minus 3 or fracture. It then received its streamline authority, and for a T-score less than minus 2.5 or fracture. When I mean by streamline authority, I meant you just don't even need to call the authorities. You just write a code on your script and you'll get it. It was approved for men in 2013. Amgen reacquired denosumab distribution in 2015, and the uptake improved significantly after. So if you look on the right-hand side of a paper in general practice, and this is not across all general practice, this is only on the database that the general practices agreed to be on. You can see that from 2015 onwards, the proportion of DMAP use increased significantly. But most importantly, DMAP also got to the populations that were not previously treated. And it accounts for approximately about 85% of all our anti-resorptive scripts. In some regional towns, you're looking closer to 95% saturation. And why can it do this? So on a private script, so if you do not meet the PBS indications, patients pay out of pocket. So on private script currently as it stands is $240. I think in about 2017 it was $390, but you can quickly appreciate for someone who's paying monthly Residuinate, and that script can be $30 or $40, depending on when you look at PBS, 6 months of oral bisphosphonates was equivalent to paying privately 1 script of denosumab. So which meant that's why it wasn't a cost barrier towards getting DMAP. And for the biosimilars, they've come in at $105. So why it's also important is because this is our treatment guidelines in Australia. And unlike here, PBS does not recognize treatment based on absolute fracture risk. So in this corner where we're trying to get people to treat based on fracs or Garvin beforehand as well, you would have to pay out of pocket. So, but that led us to quite a lot of DMAP use. And now we're faced with having people presenting to us for switching. And the commonest reasons for switching, I would say, is because GPs felt very comfortable with DMAP. We had patients that were commenced on DMAP in their early 50s, sometimes even late 40s even. We're talking people with very low absolute fracture risk. And the other thing was is transitioning to anabolic agents. Because until 1st November last year, PBS required you to have failed therapy on one of the anti-resorptive before you'll be covered for anabolic agents. So I think I'm speaking to crowds that really know about this, that we're all faced with, is the rebound phenomenon of DMAP. And we can see with DMAP starting quickly suppresses all bone turnover, and with DMAP cessation, rebound happens with your bone turnover markers. Your vertebral fracture risk also increases at that time, and your BMD gains are quickly lost. So we kind of like, I'm just gonna bear with me, I'm gonna take you on a journey that we've been through as a group. So I'm referring to this paper because obviously a lot of people know, we quickly realized that bisphosphonates was not enough to cover the rebound phenomenon. And this is from our colleagues in New Zealand, because I think he was one of the early people that presented to us in 2016, as he had people that finished DMAP on the Freedom trial. And for those who may not know, but New Zealand actually received DMAP even in the last 4 years only. It's been really late. So he had to give Zelendronate, and Zelendronate didn't obviously prevent the loss from DMAP. But looking at the RCTs so far, and the four main ones after DMAP RCT, about 2 years, Zol 5 milligrams versus ongoing DMAP, the BMD was stable. Similar study, but published later, the DST 2 years, also Zol 5 versus ongoing DMAP. And in this study, interestingly, they noted that the bone density was stable in those who was less than 3 years of DMAP and decreased in those that were greater than or equals to 3 years. And if we look at Zolamab, the Benti-Langdal study, where the average duration was longer, 4.6 years, plus minus 2 years, and they gave Zol 6 months, 9 months, and a BMD decline in all groups. And the other one was a short-term DMAP study, and was stable on Zelendronate and decline with raloxifene. So like many people, we have tried many, many things, oral bisphosphonates, repeated IV zoledronic acid, combination of above, and we are quite blessed. We've been able to check our bone tumor markers, P1NP, CTX, every 4 to 6 weeks, basically whenever we want to check in. But I think our light bulb moment came when we went to the bench. So in 2000, I think around 20, Michelle presented her work at our lab meeting about osteoclast recycling. So for a long time, osteoclasts have been thought to apoptose and disappear and out of the system. But what we now know is that osteoclasts are able to fission into daughter cells, osteomorphs. And these osteomorphs are transcriptomally distinct to the other cells. So they fission into daughter cells, osteomorphs, and these osteomorphs can fuse and recycle back to become activated osteoclasts. And OPG actually stops this fusion process. So if we think about DMAP then on osteoclast recycling, because in my head, my simple mind, I think of OPG like a biological version or like an endogenous version of DMAP. So when DMAP comes around, similar to OPG, it inhibits rank L. And with rank L inhibition, you stop the activation of pre-osteoclasts to osteoclasts. So you've got a growing pool of pre-osteoclasts. But importantly, because rank L is inhibited, it also stops fusion. So you've got this increasing pool of osteomorphs as well. So in combined, when we get DMAP withdrawal, we get suddenly an over rebound of like formation of osteoclasts through the huge pool of pre-osteoclasts that we've got converting to become activated osteoclasts, but also the pool of osteomorphs that have grown to fuse and become activated osteoclasts, which most probably accounts for the rebound phenomenon. And we were all very excited by the work of Michelle at that point. And then which brought us to our next work, because we were like, well, Michelle, maybe this is something that we need to look in mice and perhaps emulate and see if we can do something in mice. So which brings me to my colleague, Albert Kim, who was an endocrinologist as well, who was keen to do a PhD in that was using mice. So in this, they gave 6 to 8 week mice. Their first goal was to see whether they can emulate what was happening in human beings. So they gave OPG for 2 weeks, and then they withdrew OPG and did BMD and serum measurements as well. And to prove that OPG was similar to anti-rank L, in the first study, they had a group, the vehicle mice, and a group that was OPG and anti-rank L. And you can see with short-term course of OPG, BMD rose nicely with anti-rank L, and with withdrawal, it also decreased, and vehicle stayed the same. And TRAP, which is a marker of osteoclast activity, was also measured as well. You can see serum TRAP suppressed nicely at week 2 with therapy with both with OPG and anti-RANKL. So this is short term. It seems like we're doing quite well, but how about longer term? OPG. So they did for the longest to emulate the longer term DMAP usage. They gave mice OPG twice weekly for 8 weeks, and then withdrew OPG. And with that, the BMD increased nicely and more. And you can see with withdrawal of OPG, the decline in BMD was actually greater and faster with those that had longer term OPG. And similarly with the trap rose at week 14, from week 14, which actually predates the decline of BMD. So, and going back now, because we want to see, their goal was to see whether they could find a marker that they could measure, that they could give that perhaps predates the decline in BMD and how that compares to what we use clinically with CTX and P1NP. So going back to the 2-week model, they OPG was given for 2 weeks and withdrew, and you can see BMD increase, and then the BMD decrease as well. So trap was measured, and you can see from this diagram that the trap actually started rising before the BMD decreased. And more importantly, if we look at the transition period, so week 2 and 8, trap, CTX, P1NP, all 3 markers were nicely suppressed. But in week 11, we see that trap rose, whereas CTX and P1NP actually still suppressed. Then by week 13, it's where we see all the 3 markers rose. So in summary, they've managed to demonstrate the temporal changes in osteoclast formation and activity with RANKL inhibition and withdrawal. And the serum TRAP5B and RANKL increase actually before the clinical bone turnover markers, which brings us to, there was a question about whether there's a potential early intervention window that we're not really getting to clinically. So which brings us to the next study, where they tried to do it, they tried to emulate how we do it clinically. So in the growing mice 6 to 8 weeks, back to 2 weeks of OPG, and then OPG withdrawal, and they measured serum TRAP, CTX, and the rebound BMD loss, which we see correctly so. And so in the first group, the first study, they gave ZOL like the way we gave ZOL clinically, where they give OPG, and then the ZOL was given at about week 12, where you expect the CTX to increase. And you can see that after giving ZOL, so the green group are the OPG plus the ZOL intervention group, at week 12, the CTX was increased both in the OPG and OPG plus ZOL group, and in the week 14, the ZOL obviously suppressed the CTX. So we were like, well, Albert, we need to give the ZOL a bit earlier, like when the trap rolls and not when the CTX is actually rising. You can see that the trap in week 10 was already increased, which we didn't see with the CTX group. CTX was still suppressed at that point. So which brings me to the most recent study where they gave, they had 3 groups of mice. One was just OPG alone. One group received 1 dose of ZOL, the early ZOL, when we said we want to give it when the trap was rising. And another group got actually ZOL in early and late, so 2 doses of ZOL. And to try to get it to the closest we can get it, they could get it to how it'll be like clinically. For this time, they used skeletally mature mice compared to the earlier studies when the mice were about 6 to 8 weeks old, 26 weeks. And they gave OPG, 3 doses of OPG per week, 3 per week for 4 weeks. And we can see, so in the vehicle mice, obviously BMD declined. And OPG mice, like we expected, OPG, they just went up. BMD went up with OPG with treatment, and then declined quickly with withdrawal therapy. Now, in the OPG that received the single dose of ZOL early, when we expected TRAP to be rising, it was actually able to maintain the bone density and maybe decrease a bit back towards baseline. However, giving those that received the 2 doses, one where we expected TRAb to be rising, and the second one where the serum CTX is expected to be rising, you gave a more sustained response. So if we look at serum TRAb, because that's the one that we've been interested in following along, you can see week 7, they were all suppressed. And week 11, the OPG group, the TRAb's already risen. Those that received a single dose of the early ZOL and the 2 doses of ZOL, the TRAb stayed suppressed. And week 13, week 15, similarly as if we compare the second group got a second dose of ZOL, you can see that the TRAb stay more suppressed and more sustained effect with those that receive a second dose of ZOL. So with that, we know that acting early on was good, and 2 doses would tend to mitigate things better and provide more sustained effects. So in summary, as I said, early ZOL prevents the serum TRAb overshoot, and 2 doses of ZOL was superior in consolidating BMD gains. So taking that into clinical practice, we as a group have planned ahead, and I'm sure everybody plans ahead. We have elected to either use oral or IV bisphosphonates pre the due date of denosumab, and that's for various reasons why we use oral bisphosphonates. Number one is infusion centers are not as easy to come by. So for us, a lot of time is either going to the main hospitals, and that's just not realistic for our patients that are in remote or regional centers. And some patients do prefer oral medications. So we would start oral alendronate about 3 months prior to due date. And if it's not tolerated oral alendronate, we would use residuonate because we have the enteric-coated version at home. And then we would check a CTX approximately 2 to 3 months post the due date of denosumab. And if patients can either, we can give ZOL because we need to rescue, or more likely continue, or just to consolidate. Even some people get tired of taking oral bisphosphonates, or continue with oral bisphosphonates too. And how have we done so far? And this is a sample audit of the few patients that we've gone on to, about 30 patients or so. Actually, there's more being collected. Unfortunately, we do not have electronic EMR in our health system in my particular hospital. So my fellow is hard at work trying to collect more data for us. Looking at this group, the age is about just under 70, which would, I think, make sense. It's usually when we would think if patients are in the 60s, we want to transition them. DMAP duration is about 4.5, but some have gone out to 7 years or so. And whilst on DMAP, they have improved their bone density as expected, 10% in the lumbar spine, about 5% in the hip. And I would say this is not the best data yet because this is still the early part, and later on we got better at it as well. The percentage BMD after transition, it's about -1.8, -1.6, which I think it's still within measurement error. And with that, I thought I would talk about how we transitioned to romosozumab after denosumab. So this is looking at and some data that's unpublished that it's being collected now as a manuscript. So for those who might not know, romosozumab only arrived in Australia really quite late, as trying to meet the authorities' negotiated price. So looking at our own data and comparing the change in BMD according to prior therapy, I don't think it's new to most people. If you're treatment naive, your percentage change of BMD was the best, and overall you seem to do better if you are transitioning from bisphosphonates than from denosumab. And this is our patient group, and we can see the naive patients tend to be younger, in their 60s, prior bisphosphonates, 70s, and our DMAP it's about 80s, which I think this is expected. And you can see that people on DMAP were of a higher FRAX score as well. And for the prior duration of therapy, people on DMAP were quite a few more years than the other people. But I think looking at denosumab across to romosozumab, and we looked at the time between the last dose of denosumab and romosozumab commencement and percentage change, lumbar spine bone density and vertical axis, it would seem as though and I know this is a very small amount of patients perhaps, that you seem to do better if you transition with some overlap period. So around the same time, I think some of our colleagues in other hospitals came up with, that was emerging from them as well, that starting romosozumab about 2 to 3 months prior to the due date was favorable as well. So what we've been doing is and this is still to be determined and argued, obviously, is denosumab going to romosozumab. So say with the denosumab due date, we will commence romosozumab 2 to 3 months prior to denosumab's due date, and then 3 months after, about 3 months after the due date of denosumab, if the CTX was greater than 500, we may give another dose of denosumab. The argument is that because it's now been about 6 months, 7 months since you started romosozumab, most of the anabolic therapy component of romosozumab should be completed already. And rather than having CTX go to the thousands, we rather keep it steady and not lose it. And this is a sample of my patient that is not included in the study that I just thought I'll show, is blanked out everything, but you can see this is what happened with someone who received therapy, and you can see it's about 5% lumbar spine and about steady in the hips. So in conclusion, I would say that denosumab is a highly effective anti-resorptive agent. I still believe that there's a lot of places that is very useful in, especially in our aged care facilities at home in Australia, where I would say our PCPs would routinely every 6 months just go around and inject DMAB for fracture prevention in those patients. Denosumab cessation results in rebound increase in bone turnover and loss of BMD gains. The studies provide an insight into the underlying mechanism of rebound-associated bone loss, and there's a question possible of an early intervention window. So I think the most important thing for me and our patient is define the goals of treatment and plan exit strategies if required. And with that, I'd like to thank you for your attention.
Thanks, Weiwen. That was actually the most informative talk I've ever heard on the topic. So I think we should come up with a Wisconsin protocol. And then, look retrospectively. And what comes to my mind is 3 months before the dose, after the last dose, we start alendronate. And I would like to give a dose of ZA at 7 months.
Actually, I forgot to mention. So, one of our fellows who's actually currently on mat leave, her PhD is starting next year, which is giving the dose of Zol. She's literally doing what they did in mice: a dose of Zol 3 months before and a dose of Zol 3 months after.
Okay. I mean, I think coming up with something that we can try,
I agree, and getting
and
numbers.
all of us could agree with, and then if we come up with something, I mean, that just if the patients don't lose bone much or don't lose much, that's worth reporting. What do you think, Neil?
Yeah, I think coming up, right now the world is just flailing. And I was interested in the TRAP5B, Weiwen.
Yes.
And what is it? What is that telling us that CTX is not? So TRAP is a osteoclast marker,
That's right.
whereas CTX is an actual bone
Correct.
resorption. Is this they're sort of getting ready?
Yes, correct. I think it's basically showing signs that the osteoclasts are waking up already, and so yeah, that's why I think it's a good marker.
It's not clinically available, right?
It's not available clinically.
Are osteomorphs a long-lived cell population, and the corollary to that is, do the longer you treat with DMAB, do you have a greater number of osteomorphs?
Correct. Yes. That's why you get this rebound, and yeah.
Wow.
So yeah, so I think I still remember the moments when we're in the lab meeting, Michelle was out, yay! She was so excited.
So yeah, that trap is not. I know it's not clinically available. You know, if it's hard to do, we could have. We could, like, Dr. Raff could do it for us if there's a kit.
We should. I'm very keen to see like how much it costs clinically, to be honest, because it's almost impossible. I think we only do it in like studies and stuff, and yeah.
Thank you.
Of course. Thank you.